professor at the Mater University Hospital in Dublin. And I know he performed many, he is a pioneer of intervention. He is the first man of M-plus cardiac plug for atrial fibrillation in 2008. And he also the first licensed magnetic pulmonary valve implantation in Europe in 2006. And he's also the first to percutaneous to do the reverse pulse shunt for pulmonary hypertension in the British in 2018. He is admire him very much, and let's welcome him to deliver the speech about the MFO large VSD case experience sharing. Let's welcome Dr. Kevin.
Okay, thank you very much. I'll just hopefully you see the slides. And so this was an interesting case, and I think it brings out the points we've had where we've sort of rationalized, how we should approach VSDs with, when they're in the inlet and close to the tricuspid, we use a retrograde arterial approach. And when they're more outlet towards the aortic valve, we would use a transvenous approach and bring the device in from the aorta or the left ventricle. So I'm going to go through this case, which actually in some ways surprised me as to what the MFO is actually able to do. So this was a 15-year-old with a number of significant medical problems, a chromosome 17 deletion with intellectual disability. There was also airway problems with Pierre-Robin sequence, cleft palate repair, and also PEG and a Nissen's fundoplication. But it was a very significant VSD that the surgeons didn't want to tackle, and there were recurrent respiratory infections. On a hemodynamic study, the QPQS was 3.3 to 1, so really quite significant. And pulmonary artery pressure was also significantly elevated with 55/24 as the phasic, and with a mean of 40. So I'll just show the transesophageal echocardiogram of the VSD, and maybe we could ask the audience or the panel here today whether they think it's one we should approach with a device, or whether we should just refer back to the surgeons. I don't know whether Daniel's still with us and whether he'd like to comment on the defect. Maybe he's gone off to do cases.
Yeah, no, I'm hanging on. I think that it's a big hole, but like I said, I've seen some of the cases now in Southeast Asia firsthand, and this device is remarkable. I would try this one definitely in the cath lab with this device. If I didn't have this device, I would not try a defect like this. I would send this to a surgeon.
Yeah, so okay. And I guess the other devices we have, which LifeTech make, are the symmetric, asymmetric, and eccentric membranous VSD devices, which go up to 24 millimeters, but need bigger sheaths to deliver. And we've had good experience with them, even before and since the MFO was introduced. Okay, so I will show, next will be the another view on echo, showing maybe a better delineation of the defect in terms of a short axis view. And also it's always useful during the cases to get a baseline of the tricuspid regurgitation, so that you don't fool yourself that that when you have increased tricuspid regurgitation, you sort of manage to believe that it actually isn't any different. So I think it's well worth quantitating the baseline beforehand as objectively as you can with the similar scale. And so the left ventriculogram, it's always difficult to know during these cases how useful it is. Again, it might provide a baseline for for comparing the shunting before and after, but it's difficult to get accurate measurements, of the defect in many instances with no matter what angled you use. Here you can see it's certainly a decent, VSD and a decent shunt. So what's interesting, and I think it gets back to the conformability of the device. This is what we used to start with an MFO. So we used the biggest MFO we had to see could we achieve it, and I think that can be delivered through a 7 French sheath. This may well be a destination, Terumo destination sheath, because we quite like its hydrophilic properties. Although I would say that the sheaths that come with the MFO really are really quite good and a reasonable profile. So that's the first deployment of the device, and certainly the RV disc doesn't really, it still looks really quite vertically orientated. But I'll show you what things look like on echo, and you can see there's really been a very significant increase in the tricuspid regurgitation at this point. So we're clearly catching some leaflet or cord, and that's and you can still, there's also still significant residual flow. So that's really, and there's another view of it. You can see with a bit more of the device deployed, you can see we essentially have created what looks like to be an LV. You could even call it, an iatrogenic left ventricular to right atrial shunt. And so I think this is the beauty of the retrograde approach. You really have very good control of the device and the disc. And you can see what we've been able to do there, because we really feel we need to tuck this device in deeper, into the true defect, avoiding some of the tension, chords of the tricuspid valve. And you can see we're moving it, making it back into a ball-like fashion, and then pulling it inside slowly and moving up and actually getting past a cord. And that's, allowing us to have a much better position of the right-sided disc. And you can see we have it in an inverted fashion compared to in terms of how we screwed the device onto the cable. And there you can see we've got the RV disc is good. It looks at a better angulation, and then the rest of the device has come out. Okay, and this is what things look like. There's certainly less tricuspid regurgitation now. You can still see there's certainly, because of the length of the tunnel of the VSD, that the RV disc still looks as if it's not in as, in beyond the septal tricuspid as much as one would like. And there's the LV sort of disc cone deployed with really probably very little residual shunt at that point. And then in the short axis view, you're not seeing much tricuspid regurgitation. And you can see that if we think of the circular aortic route, you can see that the LV disc is nicely circular as well and conforming to the defect with really very small residual shunt. So we were actually happy with that. And here you see a left ventricular outflow tract view. You can see the device resting quite nicely on the left side of the septum, and the aortic valve is good despite the fact that we're coming from the aorta. So we were happy with that, and we went on and released it, and that's, you can see what it's like on echo the following day, and no interference with the tricuspid valve, and no residual shunts. So really providing very effective closure in what we thought was a borderline defect, and it would sort of make you think that if we have the 1412, it would be a very good idea if the company made a 1614 or something a bit bigger to rely on it, even if it does have a bit bigger delivery or bit bigger braid. So we could conclude that the MFO device, flexible, versatile device, it's not just VSDs, we can use it for. The double screw design is really very useful because it allows us, unlike an ADO2, it allows us to screw on the other way so that we can, have a disc coming out first from the arterial side into the right ventricle, and then a lobe disc into the aorta left ventricle. And that allows us to move things around in different proportions of what essentially for VSD is that we tend to think of them a bit like ASDs, but the reality is they're a three-dimensional channel. And the low profile also allows the device to be safely delivered from the artery in children. And you can deliver many of the smaller devices through through the 4 French sheath or a Fortress sheath or whatever, or 4 French flexor if you prefer that one. So thank you very much.
Thank you, Kevin. Excellent talk and very challenging case. Any question or comment from the audience?
I just want to commend you on that case, Kevin. That was a really great result for that patient. I think again just highlights the potential of this device, that plenty of people probably wouldn't have even attempted that, and you've got a great result. Saved the patient having to have bypass and a long stay, and got a really great hemodynamic result. So I applaud you on that, and great technique. And I think it's highlights the fact that you shouldn't just accept always the first time you do something. Look for the warning signs, the redeployment, the way. And again, you just showed that it's so flexible that you can pull it through and get it away from tissue that we worry about, and it has no damage caused. And so got a great delivery in the end, and I think a really great case.
Yeah, that's what I thought, was that the aortic approach, the retrograde approach, made you able to handle the tricuspid tissue better than if you'd done transvenous, which would have been certainly our approach for many years. Where essentially you have very little or no control of what's happening on the tricuspid side, because you're actually just stretched across the tricuspid with your delivery system, and you're really just hoping that everything will align itself and when you release it. But once you've released it, in terms of the tricuspid regurgitation, it's pretty much too late to do anything about, other than converting the person to or the patient to open heart.
Yeah, totally agree.